be glad to. I have been a practicing internal medicine pediatric provider and doing primary care, so here I am to answer all those questions for 32 years, and for the past 15 years I have been working with the population in federally qualified health centers, or FQHCs. FQHCs take care of 26 million people in this country. In other words, 1 in 12 people receive care at community health centers like Cherokee Health Systems. That's 1 in 6 in rural areas. We really serve the safety net population, and we serve the underrepresented in biomedical research population that I think it's very important that we all want to reach out to. At this point, return of results has been pretty limited because we have participated mostly in population-based kind of studies, things like Million Hearts, where we obtain the information and with the patient, and we have it right away. However, we are one of the 6 pilot FQHCs in the NIH All of Us research program, and I think we've gotten some insights already by our participation. So again, the 26 million people we serve deserve and should be included in research, so how should we do that? One thing I wanted to point out as far as consent, I agree, everything needs to be as clear as possible. One study I read in the American Journal of Medical Genetics from 2012 published findings from a deliberative engagement of patients from an FQHC in Southside Chicago regarding their possible participation in research. One patient made the statement that participation may give results that they could not afford in routine care. The quote from the paper, "It gives opportunities to those that don't have insurance." We're seeing that quite clearly. One of my patients asked me, if they find cancer, will they tell me? It can be viewed as a way to have access to tests that they might not be able to afford, and we need to keep that in consideration. Our patients do suffer from problems with health literacy and computer literacy. We cannot create a monolithic conception of return of results, presuming a tech-savvy, highly motivated, English-fluent, and insured patient. Many of our patients are needing us to facilitate enrollments in patient portal. To our date at Cherokee Health Systems, we have issued tokens to enroll 72,605 patients. Only 7% of them has successfully enrolled, and many of those have required us to help them create emails and to actually show them how to get into computers. Of the ones that have enrolled, only 14% have sent secure messages back to us, and 24.6% have sent appointment communications. So there are definitely challenges in use of electronics. And we're seeing those similar difficulties in the enrollments for the All of Us program. We're having to do a lot of facilitation to assist patients. Information is often presented at 4th or 5th grade level, but that is still too difficult for many in our field. Were asked by one patient recently to explain what the word data means. We're finding that use of videos, pictures, other assisted adaptations are needed in consents, and so therefore I know they'll need them when they get results back. We will continue to be there for our patients. So let me turn for just a minute to the perspective of a primary care provider. I think it's been stated already how busy we are. It's not that we don't want to do this, it's that we have so many things we have to do. And we have so much data and paperwork, and it's just overwhelming. So now, you know, return of research results, particularly when you're talking about genomics, and I think what everybody said is correct, that we have not had a lot of training in this. Primary care providers will need more training. We'll need accessible information, e-consults, however, many different ways we could consider. You need to remember in primary care, particularly in the indigent care world, the rural areas, that a lot of primary care is being delivered by mid-levels now. These are people with 2 years of training. That's highly variable. So that's something to keep in mind as you think about participants taking results back to their primary care. In my clinic, 25% of the patients are uninsured. So, and again, if they're insured, it depends on whether the payer will pay for it or not, or pay for the consultations we need. So I think, you know, it's not even just thinking that there are not enough genetic counselors. We're going to be the people that are going to be asked to help interpret this data. There's no way around it. That's in the safety net population in particular, we're who they got. And so I think that we have to look at how we can keep primary care in the mix. If you have genetics counseling, we still have to look at that patient as a whole patient. How does that lab data fit the total care with all of the social determinants of health that we have to consider in primary care? How does that fit in? I attended a conference in April this year at Case Western Reserve University School of Law on the legal challenges to precision medicine. I also want to make the point that it was very clear in the eyes of attorneys that primary care doctors are expected to have some knowledge of genetics. I wrote down some quotes from the audience because I was somewhat taken aback. But one quote was, "Physicians must erase their deficits in genetics expertise. Not all doctors need to be genetic specialists, but all doctors should have general understanding in interpreting genetic data." So there is some liability for primary care providers in receiving these results. So we're the people that patients trust. We're tireless in our quest to do the best for our patients. We do need your help. Thank you.
Thank you, Febe.